So, if you are new to this channel, I am Dr. Himadri. In our pediatric simplified lecture series, today we will be discussing about asthma in children. So, in this asthma, we will be discussing with the GINA 2024 guideline. This is the latest guideline. GINA means Global Initiative for Asthma. So, let's start. So, what is asthma? Asthma is a heterogeneous disease which is characterized by cough, shortness of breath, chest tightness, as well as recurrent wheezing. So these symptoms are present and it varies over time and intensity. And also remember, this is also pathologically characterized by airway where there is chronic inflammation as well as hyper-responsiveness of airway towards the common allergens, and there is airflow limitations which are variable, recurrent and reversible. So again, asthma is a heterogeneous disease which is characterized by cough, shortness of breath and chest tightness and recurrent wheeze which varies over time and intensity, and also pathologically characterized by chronic inflammation. This chronic inflammation is due to hyperresponsiveness of the airway towards the common allergen, and there is airflow limitation because of this, and this is reversible, recurrent and variable. Please don't forget this. So that's all. So let's talk about the pathogenesis of asthma. So there are multiple triggers of asthma which leads to this chronic inflammation. Number one is your aeroallergens. Aeroallergen means the allergens which are present in the air, like animal dander. Suppose you have a pet and this pet, and from this animal dander there could be asthma to some genetically predisposed individuals, as well as there could be house dust mites or maybe pollens. These pollens may be coming from your trees, grass or maybe weeds, as well as remember the food allergen, very important, from egg or maybe from prawn, like that. And also, if these triggers are present, that is aeroallergens and food allergens, mostly this is atopic asthma. Atopy means the diseases which runs in family, and therefore the positive family history is a must. And also there could be associated allergic rhinitis, urticaria and eczema. These diseases are actually atopic diseases. And apart from this, we have respiratory viral infections like rhinoviral infection, adeno, or maybe RSV, that is respiratory syncytial viral infections. This could be a very important trigger. And also there could be air pollutants, like remember environmental tobacco smoking, as well as the indoor poison which is very important in Indian scenario is your kerosene burning. People cook and they use kerosene for this, and this could be a very important indoor pollutant. And also cold dry air, maybe exercise and drug induced, that is aspirin, is also very important. So we'll be starting a story here. Look, there is a boy, and the father of this boy basically taken this boy to a park, maybe a garden. So what happened? For the first time, this baby is going to get exposed to some aeroallergens like pollen, and from where our story actually begins. So this is something we called as initial exposure. So this is our pollen molecule. This pollen actually entered into the baby's lungs and eventually lodged into the alveoli of the baby. And within the alveoli, we have a macrophage. This is called as your resident alveolar macrophage. This is the duty of this macrophage is to eat this pollen, and they will eat it, and via this local lymphatic channel it will eventually go to the local lymph node. Within the lymph node, something is going to happen, remember here. So this is our resident alveolar macrophage. This alveolar macrophage via this MHC class 2 molecule is going to present this red like molecule. This red is your pollen allergen or the pollen antigen. This antigen is going to be presented towards this T helper naive cell, and once this is presented, this naughty resident alveolar macrophages now gives another signal which is called as your interleukin 4, and with via this signal, look what is going to happen. Your T helper naive cell is going to get converted into T helper 2 cell, and now this T helper 2 cell will keep on producing interleukin 4 and interleukin 5. And this interleukin 4 and 5, these molecules are a very important differentiation factor for B cell, So they are called as B cell differentiating factor. They will convert B cell into plasma cell. This plasma cell is characterized by, look here, this cartwheel shaped nucleus, and this plasma cell will produce into IgE molecule. These IgE molecules are specific for those specific allergens of this pollen. So what the IgE will do, they will be sitting over some receptors. So these are the Fc portion, this end are the Fc portion of your IgE molecule, and this is our mast cell. In the mast cell we have specific receptor. These are called as Fc epsilon receptors. These Fc receptors are specific. So this IgE molecule Fc portion will bind with this Fc receptor of this mast cell, and eventually this mast cell will be tagged as sensitized mast cell specific to this arrow allergen or pollen. So remember what is going to happen right now. Look here. So this is baby's respiratory tract, and this is the, we are basically zooming. So what actually happened here? This is our sensitized mast cell that which I just discussed. So what happened for the next time? Let's say after 2 months the baby is going to the same place with his father. So something very bad is going to happen to this baby, remember. So this pollen actually came, this pollen binds directly over this IgE molecule the next time when the baby is going to the same garden with his father. So what happened? The sensitized mast cell now received this too much of pollen. This pollen binds here, they leads to cross-linking. Most important thing is cross-linking of this IgE molecule. Because of cross-linking, they're going to stimulate this mast cell. Look, now the sensitized mast cell now is now an angry bird. They will produce these molecules. What are those molecules? These are your preformed granules. They degranulate through these preformed granules. That is, they already produced some products which are going to be degranulated, and the name of this product is your histamine. Some other product as well, but histamine is very, very important, and it causes vasodilatation, increased vascular permeability, bronchial smooth muscle spasm, and glandular secretion, increased glandular secretion. Remember, this is the airway of the baby. This is the normal side, but this is the pathological side. What happened here? This is the blood vessel. Because of histamine, there is dilatation of this blood vessel, increased vascular permeability. Therefore, there is local edema, as well as there is increased glandular secretion. These greens are your glands, and this is increased glandular secretion. And ultimately, remember, there is bronchial smooth muscle spasm. So these are the bronchial smooth muscle. They undergo spasm, and eventually it narrows down the airway, and the baby now has this respiratory distress. Some other molecule which mast cell is going to degranulate are proteases. This proteases basically leads to much more amount of tissue inflammation. So all these things basically happen within minutes of exposure to this allergen. So therefore, this is which is happening within minutes. We call it early phase of this type 1 hypersensitivity reaction. So remember, here we had antibodies, that is IgE molecule, and pollens are coming and attaching to these IgE molecules, and this reaction we called as hypersensitivity reaction type 1, and this is the early phase of it. So our story not yet ended. We have another thing as well. Because of this cross-linking and stimulation, this cell membrane, from the cell membrane of the mast cell, some other products are going to coming, which we call as membrane phospholipids, like leukotriene B4, leukotriene C4, D4, and E4. And remember, leukotriene B4 is the strongest neutrophil chemotactic factor. That means they attract the neutrophil the best. That is, they are the strongest attractor. So neutrophil will come to that place, and now neutrophil will play some game, and the baby will be in more trouble. So leukotriene C4, D4, and E4, they leads to the same things is that are done by your histamine, like vasodilatation, increased vascular permeability, bronchial smooth muscle spasm, as well as glandular secretion. So there are some other molecules is like PGD2. PGD2 means prostaglandin D2. They leads to increased glandular secretion. So now you must be thinking that our body is responding in such a way that the baby is in great trouble. But why? Our body will make ourselves in trouble? No, no. So actually what happens? These are the molecules that will constrict the airway. Why? Because body wants a response here. They don't want this pollen to come further again. So that is why this is a response, but this response is too much exaggerated so that the baby is in trouble. But initially it basically tries to help you, but no longer it can help. So we talked about the early phase. Now in the late phase, what is going to happen? So remember, so this cross-linking also stimulates the DNA, and from the DNA there is a DNA replication, and from that we have eventually protein production. So it takes some time. So initially whatever happened, that was preformed or it was formed early, but it takes a lot of time to produce this. So what are going to be produced are your cytokines, chemokines, and growth factors. Therefore we call it late phase. Okay. So some notable example is your interleukin 3 and interleukin 5. They are very, very important chemotactic factor for your eosinophil. This eosinophil is going to invade the place and they are going to produce your major basic protein and eosinophil cationic proteins. These are the proteins which act over the airway, and also it damages the airway, further leads to much more amount of inflammation. So this is your normal airway. This is our asthma airway. So there is increased vascular permeability. Remember, there is too much of edema and also too much of secretion. So, and also at the end there is airway remodeling, bronchial smooth muscle hypertrophy and hypertrophy of the mucus gland, increased vascular permeability, deposition of subepithelial collagen. So this is our asthmatic airway. Now the baby is in great trouble. So pathologically we can summarize it like type 2 inflammation. Why type 2? Because T helper 2 is mainly involved in the pathogenesis. Therefore mainly this inflammation is called as type 2 inflammation. So don't confuse here. We have type 1 hypersensitivity reaction. That's a different thing, is a part of our pathogenesis. But this inflammation type is called as type 2 inflammation because T helper 2 cell is the primary player. And also we have non-type 2 inflammation. Why non-type 2? That means T helper 2 is not going to get involved here. So here we have T helper 1 cell and T helper 17 cell. They are very important chemotactic factor of your neutrophil. They will attract the neutrophil and these will produce your MPO, myeloperoxidase, reactive oxygen species, and elastases, and that will lead to airway remodeling. Okay, so again our hallmark of asthma is your chronic bronchial inflammation with eosinophilia, bronchial smooth muscle hypertrophy and hyperactivity. There is increased mucus secretion and intermittent reversible airway obstruction because of all of these things. Now this is very, very important. There is intermittent and also the obstruction here is reversible obstruction. Okay. So again revise. So this is a heterogeneous disease characterized by cough, shortness of breath, chest tightness, and a recurrent wheeze which varies over time and intensity, and pathologically characterized by chronic inflammation, hyperresponsiveness towards the common allergen, and also airway limitation which is reversible, recurrent, and variable. So, and also the triggers most important are your airway allergens like animal dander, pollen, house dust mite, and food allergen. They eventually leads to atopic asthma. We have respiratory infections as well, these viruses, as well as kerosene, remember, and tobacco, we should not forget. So what is the pathogenesis? There is initial exposure, the first time baby is going to the garden, and eventually this pollen comes and all this T helper 2 mediated interleukin 4-5 production, and eventually B cell is going to be converted into your plasma cell, from their IgE and mast cell sensitization. Next time the pollen comes, they leads to cross-linking, and eventually the sensitized mast cell degranulates, becomes totally angry bird, and eventually they produce your histamine. This histamine is going to produce too much of mediation here, and they leads to vasodilatation, increased vascular permeability, and all that eventually leads to asthma, and there is respiratory distress initially. This is the early phase. Early phase also contains production of your membrane phospholipids like leukotriene B4, C4, D4, E4. B4 is your strongest chemotactic factor for neutrophil, and your PGD2 that increases glandular secretion. We have another molecule as well called as PAF, that is platelet activating factor, that also leads to the same thing. This is your early phase, and we have late phase. In the late phase, what we are having, we have this DNA, and this DNA is going to produce some proteins like cytokines, chemokines, and growth factor. As all this production requires some time, we call it late phase. Interleukin 3-5 are most notable. They will attract the eosinophil. Here there will be major basic protein and eosinophil cationic protein, and eventually airway remodeling. This is all about our asthma pathogenesis. So if you are still watching me, you could have enjoyed this video. So consider liking this content as well as subscribe to my channel for more such videos in the future. Thank you.